Good evening, everyone, and welcome to part 2 of our series, Demystifying Medical Aid in Dying, the Facts. I want to let you all know ahead of time that this webinar will be recorded. If you do ask any questions or communicate with us at all throughout the series tonight, that part of it is not recorded, but we will be able to send this to folks after the fact. Another little bit of housekeeping, there is a Q&A box at the bottom of your screen. If you click on that, you can ask a question at any point throughout our presentation tonight. We will have a question and answer session at 7:45, but if you'd like to ask anything before then, you can feel free to send it in. That way we'll be ready to answer your question when we do open up that session. Additionally, if you don't want us to know who's asking the question, you can check the Send Anonymously box. And before we begin tonight, I'd just like to take a moment to thank all of our first responders across the world, not just our country, but the world, who have stepped up and helped throughout this pandemic. Also, all our lawmakers and all of those who have been on the front lines during this unprecedented time. Mandy, I'll turn it over to you.
Hey everyone, before we get started, we did want to tell you all about part 1 of this series, which was called Family Voices. And if you missed it, give you a quick recap, D.S. Moss of the Adventures of Memento Mori podcast was joined by special guests Dan Diaz and Myra Schulman for personal perspectives on the use of medical aid in dying. Dan shared the story of his late wife, Brittany Maynard, who had to move from California to Oregon in 2014 so she could utilize Oregon's medical aid in dying law to peacefully end her suffering from terminal brain cancer. Because of Brittany's story, which received a lot of media attention, and because of Dan's advocacy, California adopted a medical aid in dying law the year after Brittany passed. And shortly after that, Myra Schulman's mother was able to take advantage of that option in California. So if you'd like to hear about these firsthand accounts, we will be sending out a link to the recording in the follow-up email after this talk. So you'll be able to listen to all of that after. Now we'll just introduce the panelists. So if we can go to the next slide. So first of all, I'm Mandy. And I'm the co-founder and president of Keeper, which is a collaborative online memorial platform. And we were founded in 2013, and we essentially help families preserve and share the life story of a loved one, as well as plan an in-person or virtual funeral service. And I'm also the editor and co-founder of the death positive media site, talkdeath.com. So if any of you are joining from either Talk Death or Keeper, thank you so much for following and for joining us. And our next speaker is Amanda Cavanaugh, who is the campaign manager at Compassion and Choices. She worked on the campaign to successfully pass New Jersey's Medical Aid in Dying for the Terminally Ill Act and works on the campaign to pass similar law in New York State. Prior to working with Compassion and Choices, she completed training for medical assisting because she has a passion for helping people. Amanda also worked in the health insurance field, specializing in helping people access Medicaid and Medicare. So thank you so much, Amanda, for joining us. And next up, we have Jill Schock, who is the owner of Death Doula LA and has been working with the dying since 2009. Jill believes in empowering her clients to step away from the negative stigma of death and embrace style and choice as end-of-life approaches. Jill has been working with the medical aid in dying law since it was passed in 2015 by Governor Brown in California, and has seen how peaceful transitions can be when the dying have the opportunity to take their death into their own hands. And now before we really get started with the questions, I'm going to pass it back to Amanda, who's going to give us a good introduction on the subject of medical aid in dying.
Thanks so much, Mandy. So we're talking about medical aid in dying this evening, but really what does that mean? Medical aid in dying is a medical practice that provides an eligible, terminally ill, mentally capable adult with a prognosis of 6 months or less left to live, with the option for medication that they can decide to self-ingest to peacefully end their lives. Right now, 1 in 5 adults live in a state in the US where medical aid in dying is authorized. There's 10 jurisdictions that have this option, and 6 of those jurisdictions passed in the last 5 years. The first law became in effect in Oregon in 1997, followed then not until 2008 by Washington and Montana, then following Vermont, California, Colorado, DC, Hawaii, New Jersey, and Maine. So as you can see, this option is available in a variety of states across the country. Currently, there are 20 states that are considering legislation in 2020. So you can see where the light blue is where an option currently exists for medical aid in dying. And then the dark blue states can show you where there is legislation pending that we hope to see pass in the coming years. Mandy, do you want to ask us our first question?
Yeah, so we have this next slide up because it's really important to be setting the stage for this conversation. And that's really just about the terms that are often used interchangeably to describe the process of medical aid in dying, but they're really distinct. So Amanda, can you start by explaining to us what the difference between medical aid in dying, euthanasia, and suicide are, and why it's so important to differentiate?
Absolutely. So a lot of people use these terms interchangeably, and often people will say that they support assisted suicide, and they're not saying it in a negative way. They actually do support this idea. But language is so important when we're talking about what this is. Medical aid in dying, first and foremost, is not euthanasia in the United States. And the reason being is because someone has to take the medication themselves. Nothing is being given to them. So this idea that it has to be self-administered really makes the distinction between euthanasia and medical aid in dying. Additionally, when we're talking about the difference between medical aid in dying and suicide, there's a few key pointers here. When someone's using medical aid in dying, they have to be terminally ill. They're required to be within 6 months of passing. Generally, when someone is suicidal, they are in fact not terminally ill. They may have a mental illness, but they're not within 6 months of their life. They could otherwise go on living. When a person is looking for the option of medical aid in dying, they have to have the mental capability to make a decision. Often folks who are going to participate in suicide, they are mentally unstable to be able to make any sort of decision. We know firsthand that the people who are using the practice of medical aid in dying want to live. They would love nothing more to live, but their disease is killing them. People who have suicide on their mind are folks who are wanting to die, or their illness is telling them that they want to die. With medical aid in dying, the ending is planned. Often it's a celebration, there are friends or family around, and it becomes this experience, bittersweet, but an experience. With suicide, the end is often impulsive and by themselves. Medical aid in dying provides a gentle death. A person takes a medication, and we'll talk more about that in a few moments, but they take a medication and they fall asleep. With suicide, this is often a violent act using some sort of firearm. Medical aid in dying the data shows us that the person is connected to loved ones. Loved ones are around, they're involved in the person's decision, and they're surrounded by family when they pass. Suicide is an isolation. It's acted alone to avoid legal peril for any remaining family. Medical aid in dying allows for the family to have a normal grieving process. Unfortunately, when someone uses suicide, there's often a lot of abnormal grief and shame for the family. They feel very torn about the grieving process in a way that they don't when someone uses medical aid in dying. Jill, do you want to talk a little bit about what you see in your role as the difference?
I see a lot, what you're saying is all true. I've worked with people who have done the process for medical aid in dying, and I've also worked with people who were suicidal and were trying to make a plan for suicide. And I will say that there's a difference in goals, like you were saying, and there is a difference in the outcome, in how they do it and what they use. And I've actually been able to talk a lot of people into doing and like working towards eventually qualifying for medical aid in dying, instead of feeling like they have to plan for some kind of violent death for something in the future. So I think even having the option actually has lowered, some of the need to do suicide. So, but yeah, and I always look at it, euthanasia, that's what we do with our pets. That's like someone putting the needle into the animal. And actually that's okay in Canada. You can have it medically supervised, right?
Yeah, I was actually going to jump in and just say if there's any Canadians that are listening. I'm Canadian, so I'm going to represent a little bit. I don't know a lot, but some of the information, and a very important distinction is in Canada, you actually can have clinician assisted or clinician administered medical assistance in dying. And even on the Canadian government website, it was previously known as voluntary euthanasia. So in Canada, you can administer the drug yourself as the patient, or you can have a nurse practitioner or a physician administer it for you. So euthanasia could be seen as as an accurate term in Canada, but the correct term now is clinician administered medical assistance in dying.
I like that. That's good language. And I really also like that choice is available. Obviously I'm an advocate for choice being here. So I like that they have that option. And, like Amanda was saying, with suicide, people typically want to die for some reason or another, and exploring that reason might open them up to different options.
Right. So why do people choose medical aid in dying? And who typically, from what you've seen, is actually requesting it, but also who qualifies for it? Amanda, do you want to get us started with this one?
Sure. So to qualify for medical aid in dying here in the United States. So I'm in New York, and I worked on the campaign in New York and New Jersey, and I'm very familiar with the state's campaign. So I don't want anyone to think that I'm spitting facts about Canada, because I don't know for sure. So here in the US, a patient has to be an adult, meaning 18 years or older. They have to have an incurable, irreversible disease, meaning that if someone has diabetes, that alone wouldn't qualify them for medical aid in dying, because that's not necessarily a terminal illness. When we talk about terminal illnesses and who uses this, it is often people who have cancer, ALS, some sort of neurodegenerative disease. Those are the folks who often use it. So an age, you have to be over the age of 18. You age yourself does not qualify you for medical aid in dying. Your age, you have to be terminally ill. Two doctors have to confirm the patient's prognosis, meaning that maybe your primary healthcare doctor and your treating physician, perhaps an oncologist or a cardiologist, whoever you're seeing for your ailment, are often the people that are signing off on this. You have to be mentally capable to make this decision. So just as if a patient wanted to sign a do not resuscitate order, they have to have the mental faculties, and the doctor has to determine that they have the mental capacity to make that decision. They're also making that qualification as you're making the request. A request for medical aid in dying has to come both orally and in writing. Often two witnesses are involved, but that varies from state to state. But again, what we often see are patients who are end-stage cancer and neurodegenerative diseases like maybe ALS, MS, things like that, when they're in their final 6 months of life.
So Jill, you've actually assisted or have sat with individuals who have taken the medication.
Yeah.
What state are they generally in? Who is generally taking this medication, at least as a death doula, from your perspective?
So these people tend to be really good self-advocates already. They tend to be aware that the law is already in place and it's something that they can access. And they tend to have had their eye on it for a while, whether they had already been suffering with cancer or not. A lot of people were like, I'm so glad this is legal because this is what I wanted, was access to a peaceful death. A lot of cancer, typically, and, you know, unfortunately, some people I meet, their cancer is progressing too fast. In some states like California, there's a waiting period. And in that case, we can work with hospice to create a different solution. So a lot of cancer patients, sometimes ALS, it depends on what their capabilities are. Because unfortunately, if you can't pick up a cup or, like, you know, suck in through a straw or put it in through your feeding tube, if you're not capable of administering it to yourself, you're not qualified to take the drug. The same thing goes for people who have Alzheimer's dementia. Even if they've written a directive beforehand, and I think we're kind of working on that, but they won't have access to this drug because in that moment they must be mentally capable. And we'll go into it more later, but always, 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 before I give them the cup with the straw or whatever, I say, you know that this will end your life, you know, and that's the last question I have for them. And they say, yep, give it to me. So they tend to be pretty tenacious, courageous people. One woman I worked with, she was a Black woman, and she actually was the kind of woman who carried her advance directive with her on an airplane. She was so prepared, and she advocated for it right away. And it's cool that she actually got a cool medication. It was like chocolate flavored. I'd never seen that. So
what? That's amazing. Yeah. So if someone wants to have this treatment for themselves or help a family member receive this treatment, what's the actual process? So, you know, you kind of touched on that originally, Amanda, talking about they have to have 2 doctors to sign off on it, but what's really like step A to Z? Amanda, do you want to maybe start us off on that one?
Yeah, sure. So the first step really is once the patient gets their 6-month prognosis is when the process can really start. But I'm going to back it up even further and say that at Compassionate Choices, we really encourage people to talk about what it is they would want at their end of their life almost immediately. I don't have a terminal illness, but my primary care physician knows full well what's important to me and what's not, and that I support medical aid in dying, and that should I ever need it, this is an option I would want available for me. So having those conversations always is the first step for me, I would say, is making sure that the doctors that you're seeing and that your family knows how you feel, filling out your healthcare proxy and your advanced care directive forms. But should you find yourself with a terminal prognosis and you want to access medical aid in dying, the first step is to ask your doctor and make the first request. That's when the time starts. So sort of as Jill was alluding to, some states have a waiting period where there's 15 days between the first request and the second request. So if you know that this is something that you might be interested in and you have a 6-month prognosis, the first thing to do is ask and make your first request. From there, I'm going to let Jill talk a little bit about the ins and outs look like, because she's actually shepherded folks through that process.
Yeah. So everything you said, and making sure we get that date recorded with a doctor that's going to work with us. I think the first thing I want to make sure is, like, will your doctor do this? Will the hospice doctor do this? The easiest way to get through this is to be on board on service with a hospice where their doctors will sign off and they have a prescribing pharmacy, because those pieces are that's what can make or break whether or not you actually have time and access to get to this medication. So finding the doctors, if we can't find, if your primary doctor says no, because we didn't have this conversation. And by the way, Amanda, I have also told my doctor that this would be coming in the future. So if she doesn't agree now, I would like to know so I can search now for a doctor that will have these conversations. Very important. So we have to find those doctors. Luckily out here, we're in Los Angeles, California, I'm supported very well by Kaiser Permanente. They have like a whole system where people can walk through, but also various hospices can choose to have their doctors sign off so people can go through that process quicker. Otherwise, we're hunting down one doctor and a second doctor. It could take forever. And then we're having to hunt down the final piece of the pharmacy. And it's the pharmacy's choice, just like it's the doctor's choice, whether or not they're going to compound a lethal medication. And that's just personal ethics, whatever, it doesn't matter. But, or if they have the capacity to do that. So then finding that final piece, getting the prescription signed off, getting the prescription made, getting it delivered to the house, and then the client finally has it. So it's a lot to survive. And people are always like, well, are they sure that they really wanted to do this? And it's like, yeah, they're sure, because this has taken so long to get through this process. So
you really do have to think ahead with it. And what about, because I know in some cases, for some individuals, it's like a matter of days, where they would be needing to take this medication. Just like from the pharmacy, can it take like a long time for them to create the compound, or I guess it depends on the pharmacy. Yeah. Okay.
Yeah, it would depend on if they have what they need in stock, because there's at least 3 components to this medication.
Okay. Yeah, I would just add too, it's important to know that depending on the person's diagnosis and how long they've been ill and what have you, what might work for one person might not work for the other. Sometimes doctors will prescribe a certain compound, other times they need another. So it's really not a one size fits all. It's a personalized approach. And so depending on, what you need, it depends on if the pharmacy has it available. And just to make a little note, I just want to blip this in that it's clear, just like it's optional for a patient to choose this if they're terminally ill and to have a conversation with their doctor. It's up to the doctor whether this is something that they're willing to participate and prescribe in, just like it's up to the pharmacy. So no one is forced to be involved in this process whatsoever, which can be challenging if you live in an area where there's not a doctor that's willing to prescribe. But it's also part of the protections for doctors to follow their own code of ethics. Same with a pharmacy.
So let's just kind of jump into that really quickly. And we did talk about this a bit in part 1. Why are doctors or why are pharmacists not prescribing or making this medication? I know it's a tough question, but I think we know part of the answers. Jill, do you want to jump in on that one?
I'll tell you what I know and what I experience is that I do work in a city that has Catholic healthcare systems, and it's just not a part of their code of ethics to offer medical aid in dying. So any doctor that's like signed, and there is debate in the physicians community about whether or not a hospital can tell you how to practice medicine. But it is in their ethics, and they will there will be consequences. So I know that it's always going to be a no with any doctor that's tied to a Catholic healthcare system.
Yeah, so religion plays a part. We know that the biggest opponents to this are often derived in a religious argument, or a Catholic argument is the most common. The other thing is this whole idea that physicians can heal everyone and never giving up on their patient. So some will feel as if they're abandoning their patient. The doctors who support this will say, I'm actually helping my patient. If I don't support this, I'm abandoning my patient. But those on the other side might say that they can alleviate all pain and suffering. And we know that that's not true. Just like we can't heal every illness, we can't alleviate all the pain and suffering that a patient has, but some hospices and physicians will try to claim that, and that's where their opposition comes from.
You know what's so interesting about that, Amanda, is that I've had hospice doctors who won't prescribe, but then their way of like palliating the symptoms is actually prescribing the same, like, I'm like, what's the difference? I don't understand.
So there's this thing of double intention, right? And so we hear that they will give a patient morphine when they're on hospice. And their intent when prescribing that morphine and allowing the patient to take it is to alleviate the pain. The other thing that happens is that it slows a person's breathing and eventually will bring them to their death. But that's not their intent when they're prescribing it. So that's sort of how they make up for that or rationalize it in their.
Right. So on that same vein, national polls, and this is from Compassionate Choices, who polls this and has this real solid information. There really is overwhelming support for medical aid in dying among the general population and doctors. And 2/3 of Americans agree that when a person is facing a painful terminal disease, it is morally acceptable to ask for a physician's aid in taking his or her own life. And back onto the religious stats, which again was mentioned by Dan in the last talk, and that one was almost shocking or surprising to me, because religious traditions are often described as a barrier to receive medical assistance in dying. And like Jill just mentioned, some Catholic or more religious hospitals or institutions will not allow their doctors to prescribe it, but 70% of Catholics, 59% of all Christians, and 53% of Protestants in America support medical aid in dying. So with all of this overwhelming support, or for what it seems to be overwhelming support, why are there only 9 states that have authorized this option right now? Amanda, do you want to jump in with that one?
Sure. So it's becoming increasingly popular in that, there were over 20 states this year that introduced legislation, which was a huge victory for us. But when you have these archaic medical societies and medical groups that will oppose it, and the Catholic Church, as we know, that can be very involved in legislative activity, it's challenging to pass these laws, because lawmakers are looking to medical professionals for answers and support, and they want their guidance on passing this sort of law. And some of the opposition is very strong. So we know that when we poll Catholics, 70% of them support this. However, on Sunday, if your priest tells you on the way out, sign this petition, I think you need to oppose this. People do, they listen. And so it's not always the issue that people are out on the front lines fighting for. I mean, our country has a lot of work to do. We have a lot of social injustices. And so people are fighting for daily human rights every day. They're not focused on trying to, be in front of the legislature to pass a medical aid in dying law. And so it becomes difficult, and that's where we are. We know that people support it, but it's really making sure that lawmakers know that, so that they pass these laws and people can have access.
Yeah, legislation is hard. It's a lot of work. But I mean, how many states? 5 in the past 5 years. So that's 1 a year. So I think legislation is picking up speed, because that timeline, there's kind of a jump there, and you can see it's getting better, much thanks to the advocacy and the legal team at Compassionate Choices. Yeah, legislation is just hard, and there's a lot of other things going on. So
yeah, and at the end, we'll definitely have a little call to action to explain to all of you how you can help advocate for it in your state, because it's so important. As we can see, it really does change a lot of people's lives. So Jill, you've sat with individuals who have utilized the medication, and you can watch How to Die in Oregon, for example, a documentary that talks about and really shows that process. But you've really sat with people when they've taken the medication. Can you talk to us or kind of illustrate that experience for the patient, but even the family and the people that are around them when they take it?
Sure, thank you. So the whole reason I'm there is so the family can do all of this themselves. Once they have a medication, they can mix and take the medication themselves. But it tends to be the case that nobody wants to touch the lethal medication, not even hospice. And there used to be more volunteer resources for people who would just come over and mix the medication and be there. And those are a little bit harder to find these days. They're still out there. But essentially, that's what I come to do. So I come over to mix the medication. Back in the day, we used to have capsules that we'd have to undo. And I would just go into the kitchen or at the dining table and let the family sit in their room and undo these capsules for like 45 minutes. And you kind of like make it up in a paste, but now it's a lot easier. It just comes in a powder that you add fluid to. So even though that's all I'm doing and putting things in a row, making sure they take their anti-nausea medication, just giving the timeline. And then when they're ready, making the medication and then giving it to them. And then I typically just go sit in the corner and take notes on like time and breaths. But it's when I'm getting ready to make the medication, the families are typically like, it's like that feeling of going up a roller coaster, where you're like anxious because, this is going to be a crazy ride. And then after the client takes the medication and they just slowly go to sleep, and the family's like holding them and talking to them and loving on them, it's like then they get it. Then they're on the roller coaster ride and they're just going with it. And it's so precious, like to see people actually get to die in their loved ones' arms, saying like, I'm here, I love you, say hi to mom and dad, and telling stories. And typically the deaths go pretty fast, typically an hour or less. I've had one be like 6 minutes. I've had one be like 60 minutes on the dot. And that was kind of funny because that was that guy's personality. Because if it takes longer than an hour, I want to make sure that hospice might have some backup medication, just in case we need to push anymore for whatever reason. But it tends to be a really beautiful experience, and it's always been an honor for me to just be in the corner and be able to like watch a family say that final goodbye. So it's always been a beautiful experience for me.
And can we just touch 1 second? We talk about this process being volitional, but there are, it's not just one medication that the patient takes at the end, right, Jill? So they actually have to prepare the body, which is just so important that every step of the way patients are making that decision, right? They made a decision to ask their doctor. They made a decision then to do that again in writing or orally if they have to. They make a decision to fill the prescription. They make a decision then to take it. But the day that they take it, there's 1 or 2 medications that they often have to take ahead of time to prepare their body, and then the final medication that they take. So the whole idea behind this is that it's all volitional, and I can somewhat foresee the future that people are going to say, well, what if you change your mind? And you can, and that's the best part about it. 1/3 of the people who get the medication never actually take it because they are receiving the comfort that they need from hospice. In Oregon, where this has been a law for over 20 years, 91% of the people was the number last year of those who were enrolled in hospice. So medical aid in dying is not just you know, if I decide to take medical aid in dying and go through this process, then I can't use hospice or palliative care. You can. The majority of people, 91%, actually do. And so it's important to know this is just a tool in the toolbox, and that you can always change your mind at any point. And people do. A third of the people do. So I just want to highlight how volitional the process is from beginning to end.
Yeah, and that was actually going to be a follow-up question for Jill. Like, within your experience of, you know, even going to the house with the medication for the patient, has anyone changed their mind, like, before consuming the drug?
Yeah, they change their mind all the time, and it gets delivered by the pharmacy typically. Like it's like a very careful process with that. But typically they already have it before I get there, and they had been waiting to take it. And it just so happens that they're suffering and their decline, and that it's typically like one day they really feel like shit, another day they feel terrible, and then they're like, you know what, if this is going to continue, no more. So they kind of show a little bit of a decline, and then they typically choose. And also when they do take the 2 medications they take beforehand, you know, I also ask them after they take those, we can stop here if you want to, because those aren't, you know, lethal on their own. So yeah, I've shown up, met somebody and their family for the first time, and like died with them that day. Like I've known somebody for 2 hours and they died. So it's fast, but it's easy. It's really easy, and just what a space it provides. It's great.
How's the family after the process? How are they when their loved one has died after they've sat with them?
Shocked how easy it was. They're like, that's it? That was it? They're just, wow, that was really peaceful. I'm so glad that we did that. They're like relieved and just so happy that it was as easy as, you know, we said it would be, you know. But when you've never seen something before, you have no idea. And when it's lethal, it's really scary. So they're typically relieved and happy.
Right.
And Jill, in your experience, sorry, Mandy, in your experience, you know, we often hear stories. I've been working on these campaigns for 5 years now about how empowering it is for the patient when they get the prescription. What we hear, and Jill, you can speak to it firsthand, is that a patient gets the prescription, and if you are on our first call, this is certainly something to tune into. You've heard it, or if you haven't, this is the plug that you should. They get the prescription and they put it in their medicine cabinet, and then they go on living. People feel like it's a prescription to live because they're not fearful of what's to come. They know that for the first time throughout their disease or their illness, that they are actually in the driver's seat. So for example, I'll use Brittany Menard and Dan Diaz, because they are sort of like the couple that everyone is familiar with. But once they moved to Oregon and Brittany had that prescription, she took a trip with her mom. She took a trip with her best friends. Her and Dan celebrated their anniversary together, and really had some special moments, because Brittany felt comfortable knowing that when enough was enough, she could take the prescription. Jill, do you see that a lot when you are working with patients?
Yes. Yeah, exactly. It's just there. And, you know, if they don't use it, you know, we'll go dispose of it properly. It's okay. You know, it's going to be okay. So yeah, always empowering them that they can change their mind at any time.
Yeah, it's like a tool in their toolbox. And I thought something that was really interesting that Dan mentioned in part 1 was that, and this is the case for most individuals that are that have a terminal illness, is with all the medication they already have on hand, they could end their own life if they really, like, if they needed to go that route. But this provides a safe and legal option for them to do that. Because yeah, someone could actually just take that medication that they have and it probably would kill them. But this is just helps individuals through that process. And so this kind of takes us to, actually, before we go to this next question, I do just want to say that we're going to start answering some of your questions in about 5 minutes. So if you see at the bottom of your screen, you should see a little Q&A bubble. Go ahead, ask a question. Feel free to make it anonymous, and we'll try to answer as many as we can. So Amanda, what do we know about these laws that are working in the states where they're authorized?
We know that they're working, which is phenomenal. There has never been a case of misuse or coercion in any of the states where medical aid in dying is legal. It has been in Oregon for over 20 years, and less than 2,000 people have ever gotten and taken a prescription for medical aid in dying. I think one of the most beautiful things that Dan Diaz often says, and I have clung on and repeated often, is that medical aid in dying laws do not result in more people dying. They simply result in fewer people suffering. And that is really the heart of this whole entire conversation. Patients are dying, and in terrible ways. You know, we all have seen stories, I imagine, or seen loved ones die. That's why you're on this call tonight, because you know that there has to be a better way. And there is, and no more people are going to die than already do every year. We are just going to help them die in a more peaceful and loving way. And that's what we know. We know that the laws work as they are intended to work, and that every patient should have the option, not just 1 in 5 in the country.
Great. And how can Americans successfully advocate for medical aid in dying in their state?
So I am actually the campaign manager here in New York, but we have campaign managers and from staff to volunteers all across the country. So the first and most important thing you can do, you don't have to be involved with any organization, but talk about this. People don't talk about death and dying. They're scared of it, but open up the conversation. Many of you might on this call not know that medical aid in dying is an option. You know, until 2015, I didn't know that medical aid in dying was an option for some folks in this country and not for others. And so it's important to talk. People don't know that. They either think that it's an option, or they have no idea that something like this even exists. So the first thing you can do is have conversations with friends, with family. Let people know that this is something you support. More than that, talk with your lawmakers. It's an election season. I don't want to get into how terrible that even is. But when people are asking for your vote, ask them to support this as an option and really bring it to the table. Otherwise, you can always go to Compassion and Choices and click on our volunteer button, and there's a variety of ways that you can get involved. But right off the bat, I would say have conversations, write letters to the editor about why you support this as an option, and talk to your lawmakers and those asking for your vote.
Awesome. Thank you so much. So we are getting quite a few questions, so I'm going to start getting to those. So thank you all for asking. We'll try to answer as many as we can. So this first one is interesting. Are there efforts underway to try to amend the California law? And I guess we could talk about this laws throughout the US, so that someone without the ability to self-administer could get a clinician to administer the medication for a case with someone with ALS, for example.
We are aware that this is a problem for like ALS and dementia. So there's nothing in place. There are some, Compassion and Choices does have the toolkit with like an addendum and some other things where you can like write out your wishes. But as far as getting the medication for that right now, it's going to be a while, I think. Amanda, what do you think?
Yeah, so I'll go back to the whole conversation around this being volitional. We really believe that a patient has to be in control of making this decision and doing this act. So at Compassionate Choices, changing the law to allow for someone else to be in control of the medication is not something that we see in our scope as supporting. I know with ALS patients, I've certainly heard of stories, you know, if a person can drink it through a straw, then they can have access to taking the medication. Also, if someone has a feeding tube, but they can push the button on the plunger to have the medication go through. So I know that there are ways, and that doctors often will try to work with patients. We've heard, you know, quite a bit of stories. Dementia and Alzheimer's, as Jill alluded to, we have some great resources. Again, the person has to have the capacity to make a decision when the time comes for medical aid in dying. So that's not something I ever see. You know, we are doing work on dementia and Alzheimer's. We have the dementia provision and different things available, but unfortunately, medical aid in dying is not going to be the answer for those patients.
Gotcha. Well, if you are in Canada, as if you missed this at the beginning, in Canada, you actually are allowed to have a physician assist by actually giving you the medication. So if, for example, you know someone that has ALS, maybe move to Canada and get residency and be able to benefit from it that way, if that's really something that's important to you. So the next question, one of them, I believe I know the answer is this available in New York State? Which it is not yet? Okay, so it's not available yet in New York State. So a follow-up question from the same person is it possible to go to a state where this can be done? Will one of your doctors from your home state be able to sign off on this? So what is that process like if you live in one state and you want to go to another state to receive the treatment?
So it's not yet in New York. We are in our 5th year of the campaign, and our neighbors in New Jersey have passed a law, and Vermont has passed a law, but unfortunately New York has not yet. But we're very hopeful that in the coming year. We do know that of people who move from one state to the other. For example, you know, Brittany Menard moved from California to Oregon. Keep in mind, though, you have to establish residency and you have to find new doctors. So your doctor in New York cannot be a prescriber if you move to Vermont, for example. You have to find an entire new care team. So finding not just one, but 2 physicians and a pharmacy in a time where you have a 6-month or less prognosis is very challenging. It's possible, we know that people do it, but it's very difficult. Jill, do you want to speak to that? Have you worked with anybody that has moved?
I have not worked with anyone who specifically moved to the state to do it, so I can't really add anything. But yeah, I do like what you were saying, Mandy, about, you know, going other places for access potentially, you know.
Yeah, not unfortunately, not everyone has the time and the health to be able to do that.
Yeah. And it can be very, it's burdensome, it's stressful. We actually had a supporter of ours who moved from moved from New York to Oregon. He packed up, he and his wife, they sold everything in their apartment and they moved across the country. And when they got there, he passed away in about a week and never was able to even access the medication. And so here is his wife alone in a state where they weren't from. It just becomes extremely stressful, and it would certainly be a better option to have this available everywhere.
That's why advocacy is so important, everyone in your state. So this question actually came up last week, and I'm glad someone else brought it up to remind me. What insurance covers the medication? Medicaid, Medicare, private plans? Jill, can you talk to us about that?
Well, I know Medi-Cal will cover it. Medicare won't, because they're like a federal, you know, government money pool. So because this isn't legal across all of the United States, so typically it's out of pocket, and it can be expensive. It's less expensive now than it used to be. I had a client last year who got the medication and everything for like $300. But I've also seen the Seconal medication that was like $7,000, and then the $7,000 that goes to a private doctor, you know, a concierge doctor that you have to hire. So I've seen it go really high, but the only insurance that I've seen cover it is Medi-Cal, which is California's Medicaid system.
Wow.
Yeah, I would just add it varies state by state. Some state insurance carriers, the Medicaid version of each state will cover it. It's up to the state, but any federal, for example, Medicare plan doesn't cover it because federal dollars don't cover it. Most private or group insurances that a patient would have does cover it.
Yeah, good to know, because the question for this case from Brianna was about private insurance plans. So generally, from your experiences, private insurance will cover it. Okay, great.
Yes.
All right, next question. Why isn't CNC working to get clinician-aided medical aid in dying for the 20 states that have pending legislation? Sometimes a person can take the medication themselves. So this is similar to one of the questions we had before. Amanda, do you want to jump on this one?
Yeah, I mean, so what we know is that when the law passed in Oregon, it took almost another 10 years before another state passed legislation, and the law is working as intended in Oregon. And pointing to that data and seeing, you know, that it's working is very important and a huge part of our campaigns in all of the other states. It's just, you know, the battle to pass a medical aid in dying law as it is now is so challenging that trying to amend any law that's currently on the books or advocate for anything more than a patient doing it themselves is just not feasible. Maybe in, you know, 30, 40 years, we will be more progressive as a society, but at this point, it's just, you know, it won't happen. And so we want to have some access for folks. Jill, would you disagree with that from your, you know, what you see in California?
I mean, it takes so much effort to get this like stuff passed. And I do see evolution coming. Like I'm pretty satisfied with like at least like one state a year for the last 5 years has been at least giving legal go ahead. You know, access is going to be a different thing, but I think focusing on getting everybody legal first, then we can go deeper into it. Then we can start talking about rights for people who maybe were left out of the first version of the law. And so I think it's just going to be a long-term process, but I think getting all 50 states would be a huge accomplishment first, at least.
Yeah. So the next question is an RN who's wanting to know more about the medication itself. Can you talk to us about the medication, the different types of concoctions that are created for it?
Amanda did kind of bring this up earlier, how it is a compounded medication. I would have this conversation with somebody privately, but I don't feel, as someone who's not from the medical, you know, I'm a chaplain. I'm not a doula. I'm not a nurse, but it is what I'll say is it's a compounded medication that's morphine heavy, about 15 grams of morphine. So it's a kick in the ass.
Yeah, I would just add to Jill's comment, you know, prior to California passing the law, Seconal or secobarbital was often what was used for those who might be familiar. It was a common sleep aid about 30, 40 years ago, but too much of it would bring about death. Unfortunately, the makers of Seconal actually sold it right before the California law passed, and then the drug company jacked the price way up, knowing how many people would be able to access the law in California. So physicians have had to come up with new clinical guidelines to find medication that would work for each patient. And again, you know, we could say it's often a certain a certain solution that people use, but depending on what the patient's been using, you know, someone who is in end-stage cancer that maybe has been using fentanyl and different things, they might have to have a different compound than someone with a heart disease, for example. So it really does vary by the patient, but there are clinical guidelines out there that physicians use to make those decisions.
Yeah, the second story is pretty interesting actually, because that worked really well, really well. The compounds are they work, but sometimes they take longer. Like Amanda was saying, if you have any kind of tolerance, you know, we have to be aware of that tolerance. If you've been on a fentanyl patch for 3 years, you know, we might need to up the morphine that's already there, or whatever, use more of a heart component to stop the heart, you know. So it's a conversation with the doctor, but it was big pharma that took this like super surefire, easy medication away from us.
This is a question for Jill, but I feel like this, Amanda, it'd be great for you to answer this as well for all states where it's currently legal. So this person is a practicing death doula in California, and they want to volunteer to mix the prescription so that fewer people have to suffer. And Jill had mentioned that there are fewer people volunteering for this. So how can, I guess let's start with California, but then are you able to volunteer either with Compassionate Choices or as a doula to help people mix and sit with the individual when they are taking this medication? Jill, do you want to start with California?
Sure. So right now in California, we do have End of Life Choices California that focuses on the volunteer aspect of things. So, you know, you can sign up and volunteer through them. It's kind of interesting because there's like a group of people who have historically been around for a while. Some of you might have heard of the Hemlock Society or the Final Exit Network. We do have a lot of those people who have evolved out of those movements and now have been working as private advocates to like either teach someone how to do this or to go to the house and do it for them. And that's really the capacity that I function in. But it's all about learning how to do it. So either finding a volunteer organization or finding someone to train you how to do it.
Yeah, I would kind of second Jill. So volunteers were popular, especially in Oregon, but what happened was that there was really this effort to normalize the practice of medical aid in dying and not have, you know, this outside person come in and be involved in the process. So if you live in a state where it's legal, you can certainly go to Compassionate Choices and sign up to be a volunteer, and we can help you connect with people. Compassionate Choices also has an end-of-life consultation service line that they use to help people who are trying to either access medical aid in dying or find a volunteer or what have you. Or if you don't want anything to do with medical aid in dying, they can walk you through what options are available in your state. But that would be my suggestion is volunteer with Compassionate Choices or sign up with another organization who might do something like this.
Awesome. So I have time for one last quick question. What is the law in Massachusetts right now concerning medical aid in dying?
It's in the process. They just passed one of the requisite committees. And so we are hoping that Massachusetts could potentially be the next state to authorize medical aid in dying, but it's not there just yet. They are working that through the legislature as we speak.
Great. Amanda, can I ask you to put up those last few slides again, just to close it off? Thank you so much to everyone for joining us and for engaging with us. We got a lot of questions. We couldn't actually answer them all, but what we just wanted to do is show you a few quick resources before we finish off. So feel free to do a quick screenshot if you'd like. So first of all, there's resources through Compassionate Choices, which is giving you more information about the US in particular. For Canadian, on talkdeath.com, we have some resources, but also the Canadian government. If you just Google Canadian medical aid in dying law, the Canada.ca has really great information, just answers really what you need to know and who's eligible. So I suggest that you do that if you're a Canadian on with us today. And then for the next slide, Compassionate Choices, as you know, this is really what they do. This is their focus. They're advocating for it, they're volunteering, they're talking about it. If this is something you're passionate about, follow them, sign up for their newsletter, get all those updates. Again, I'm with Talk Death and with Keeper, so those are our handles and our web information there. And Jill with Death Doula LA. She also puts on really great death over drafts events, almost like every Friday now. And they're wonderful Zoom events where you can talk about different subjects around death and dying over a beverage. So we encourage you, of course, to follow. So thank you, Amanda, so much. Thank you, Jill, so much. And to everyone who's online, again, we are going to send a follow-up email that's going to have the recording for today and the recording from last week as well. And you'll be welcome to share that. I'll probably put it on YouTube and share it so that it's widely available to everyone. So thank you, everyone, so much. And we're going to sign off now. Have a great Monday.
Thank you. Have a great night, guys.